So good morning and welcome to Grand Rounds. First, housekeeping. Please complete the surveys. We've modified them a little bit. We're trying to deliver content that you would like to see. So finish the survey, help out with our online plan so we can adjust things next year. We're trying to make it so you don't have to sit in the back, guys. We are videotaping and live streaming. Please use the microphones to ask questions. Since we're live, watch what you say. And a video of the conference will be available on the DICET YouTube channel next week. So that behind us, it's an absolute pleasure to welcome Dr. Dave Holmes. The only problem is we have an hour for the whole thing, and to introduce David and list his accomplishments would take a minimum of 90 minutes. And I can't seem to reconcile the two. So if you don't know Dr. Holmes, you're probably the only person in the room who doesn't. Many of us have known Dr. Holmes for a long, long time. And if you were to look up the word leader on Wikipedia, Dr. Holmes' picture would be there. Dr. Holmes has been the leader in interventional cardiology since I can remember. It's when my memory works. David has been a leader and a friend. He's pioneered the way in PCI well before stents were placed or thought of. He was a leader when primary PCI was a dream and performed only rarely. David is probably, more than any other individual, responsible for the development of structural heart disease as an interventional specialty. David is currently the leader of the Transcatheter Valvular Therapeutics Registry, the TVT. A few other minor things. David has been president of the ACC. He's been president of the SCAI. I think if we kept on talking, it would take up your entire lecture. So, David, talk to us about left atrial appendage occlusion, please.
I'm just going to take questions after that. So it's great to be here. The other piece of information that wasn't shared is the fact that I am the only one in the room who grew up before electricity. Think about that. I am that old. So we're going to talk about left atrial appendage occlusion, which is a pretty neat topic because it is going to be an incredibly important issue for at least 25% of you in this room. Think about that. So we're going to then talk about this issue going forward. There is a relationship here about technology that Mayo and I had about 100 years ago that related to this. So as we think about it, this is how we might start. What do these things have in common? So we have on the left, we have wisdom teeth. You all at one point in time had wisdom teeth. On the right, we then have the left atrial appendage. And the question is, what do they have in common? Well, you never know you have them until they cause you trouble. That is true. That is true. One of the things we're going to at least mention during this talk, we're going to talk about the rationale for site-specific therapy. We're going to talk about, is there a need for left atrial appendage occlusion? We're going to talk about what the neighborhood looks like. What do the new kids on the block look like? What do we know about the devices, and what are the issues related to those devices? What do we know about the match between device and patient, or between drug and patient, and then how will we get there? The first piece of information is there a need? Why might we think that there would be a problem? This is that wisdom tooth that then becomes impacted. Or this is that left atrial appendage that develops a thrombus in it during the performance of an echo. And then as the technician watches in horror, this then thrombus moves around a little bit. Now people are getting a little nervous. And then in panel C, moves out to play. Moves out to play. And then as the technician watches, it then moves away. That point in time, then, the patient develops hemiparesis. Extraordinarily interesting, and that's the rationale for what we will talk about in terms of site-specific therapy. What do we know about the issues? This is old data from 1996 that looked at the location of thrombus in the left atrium or the left atrial appendage. And the pieces of information that we know are that in those patients that have non-valvular atrial fibrillation, if they're going to develop a stroke or have had a stroke, that it came from the left atrial appendage in 90% of the time. Is it 100%? It is not. That has important implications as we think then about how do we treat patients, how do we counsel patients, but 90% of the time it lives in the left atrial appendage. Is there a need for then site-specific therapy? What do we know about the issues of atrial fibrillation? How big a problem is it? It's a huge problem, more than 6 million people. If you were to then bring it into this room, information that's available is that 25% of you, of us, will develop an upfront, close, and personal relationship between you and atrial fibrillation over the course of your life. 25%. Projected increase by 6 to 16 million by 2050. The lifetime risk we've already talked about is 1 in 4. Patients with atrial fibrillation have a 5-fold higher risk of stroke. About 90% are thromboembolic. They have the highest morbidity and mortality, and recurrence rates are high. In the past, I used to ask people in the audience like this, how many of them have already had an experience with atrial fibrillation? At that point in time, most of the time, the audience, number one, sits on their hands and look down and don't want to even have any sort of eye contact. So I don't ask that question anymore. So you're safe. I'm not going to ask that. But the final thing is that atrial fibrillation and stroke both increase as we grow older. This is an extraordinary slide. The medical field has tumbled to the fact that there's lots of interest in atrial fibrillation. If you were to do a Medline search for atrial or auricular fibrillation, since 1950, there were 270 citations from 1950 to 1959. From 2007 to 2016, there are 34,000 Medline citations. These are publications. These aren't abstracts. These are full-length manuscripts on auricular fibrillation. And so there's incredible interest in it. A couple of pieces of information. We've talked about the fact that atrial fibrillation is associated with a 5-fold increase in stroke. In those patients that have atrial fibrillation that have a stroke, they have a 15% incidence of recurrence. If you were to say to a patient, the thing that you fear the most, what is it? They would say stroke. If you were to say to that same patient, what is the second most thing that they fear the most? It would be a second stroke. And that's 15% of the time. 20% of the patients with a stroke have a prior diagnosis of atrial fibrillation. But the concern is there may be a substantial proportion of patients with stroke that have clinically undetected atrial fibrillation. What's the information about that? This is a meta-analysis from Lancet Neurology. That may not be the first journal that you open every day when you get to the office, but there's some important, really neat stuff in it. This is a meta-analysis of 50 studies and about 12,000 patients to look at the proportion of patients after a stroke or transient ischemic attack who have newly diagnosed atrial fibrillation. We all do link monitoring and other things to look for atrial fibrillation. The question is, how often might we find it in patients that are at risk for a stroke or have had a stroke? The findings were that prior studies we've talked about that 20% of patients with a stroke or TIA have had a history of atrial fibrillation. Newly detected atrial fibrillation might be diagnosed in nearly 25% of patients. So you see somebody that comes in with a stroke, they're in sinus rhythm. If you were to do monitoring in those patients after the stroke, a substantial number of those patients will have had atrial fibrillation, and you just missed it because it was transient. And if you use sequential cardiac monitoring, it will increase the yield of detection. And so it is possible, and some more recent studies have said that atrial fibrillation, either known or newly diagnosed, may be as high as seen in 40% of all strokes. Maybe it's much greater than just the 20% that we used to think and talk about. And this was their then conclusion. By sequentially combining cardiac monitoring methods, atrial fibrillation might be detected in more than a quarter of patients, maybe up to 40% of patients. And that would be a group of patients that we could then treat to try to prevent recurrences, which occur in 15% of those patients over the first year. The next piece of information is to say, well, obviously we know how to treat these patients and they're all really well treated. And I'm sure that in Houston, you make sure that everybody that has had a stroke gets atrial fibrillation precautioned with an anticoagulant. And in Rochester, Minnesota, the same would be true, with the exception of the fact that if you really look at the data, we're not nearly as good as we say we are. Now, this is old data from 2009. It's the National Database, Canadian Stroke Network, looking at patients admitted with a first stroke and known atrial fibrillation. This is that 20% of patients that have known atrial fibrillation. These strokes were disabling, and 60% they're big strokes, and they were fatal in 20%. And this is what they found. Of course, it doesn't apply here, and of course it doesn't apply in Rochester, Minnesota, except we've not really looked. So I'm not 100% sure. And so if you were to look at first ever ischemic stroke in this 600 patients, 2% of them were on dual antiplatelet therapy. 30% had no antithrombotic therapy. 30% had warfarin, but it was subtherapeutic. It's extraordinary. This is in a group of patients that have their first ever acute ischemic stroke, and somebody knows that they have atrial fibrillation. Or if you were to say, well, what about that highest risk group of patients that have had a history of ischemic stroke, or TIA? This is the data on about 400 patients. You look at then the subsequent medications that they're on. It's warfarin, 40% is therapeutic or subtherapeutic. So we don't treat these patients very well. You're going to say this is from 2009. Since 2009, of course, we never use Coumadin anyway. It's sort of passé. And so with new anticoagulants, it's taken care of the problem. The next pieces of information is taking care of the problem and whether we take care of it or not. This comes from 2016, not 2006. So it's 2016, just published. It's a U.S. commercial insurance database. It's administrative claims. You can say, well, there are problems with administrative claims databases. I know that. But it's probably the best stuff in a very large number of patients, about 67,000 patients, to look at those patients who were treated with atrial fibrillation between November 2010 and December 2014. The patients were at risk for stroke. 90% had a CHADS-2 VAS score greater than 2. 50% of them had high bleeding scores. And they then looked at the different agents that were then being used, apixaban and rivaroxaban and dabigatran, as well as warfarin. They then looked at compliance in this 67,000 patient administrative claims data. This looked at then the proportion of days covered in those patients that had a CHADS-2 VAS score greater than 4 over a median of 1 year follow-up. We can see that apixaban was the best, or maybe none of them were really the best. Because in apixaban, at a year, only 54% of the patients that we said, we've got this magic thing for you, it's going to take care of everything. Only 54% were still taking that magic thing. And many of them had never even filled the prescription for the first time. If you look at all NOACs, it was 50%. If you look at dabigatran, rivaroxaban, warfarin was obviously the worst. That is true. We know that. But the fact that we have NOACs doesn't necessarily mean that they're taken by the patients. And if you just put the NOAC underneath your pillow, it's not nearly as good. Not nearly as good. And this is the information on stroke risk. This is the hazard risk of stroke. If you have not been on anything for 2 to 3 months, your hazard risk of stroke is 2.73. If you have stopped it, you're non-compliant for more than 6 months, it's like you've never had it before at all, because your hazard risk for stroke is 3.66. So the longer you're off this, the longer you're non-compliant with the NOAC or the DOAC, increased risk of stroke, and it dramatically increases. So what their findings were, if you're very, very low risk, if you're a 0 or maybe a 1, doesn't make so much difference, but maybe you didn't need it all that much in the first place. Maybe we just don't know enough about risk prediction. Non-adherent patients' risk of stroke with a CHADS-2 VASC score of 2 or 3, the hazard risk of having a subsequent stroke if you're non-compliant are almost 3. And in the group of patients with a CHADS-2 VASC score greater than 4, it's almost 4 times the chance that you're going to have a stroke if you're not taking the medications. The next piece of information is that there are some patients that they stop it. In Europe, if you were to look at European prescription data from 2016, about 50% of the patients that are given a NOAC, the dose is reduced. If the dose is reduced, it decreases bleeding, but it also reduces effectiveness. So you're not only not taking it, but you're taking a dose that is smaller than is needed for effectiveness to decrease the chance of bleeding. These are those risks of major bleeding, lots of information on this. These are the different trials. These are the number of patients, a huge number of patients. Major bleeding with a NOAC, 2.7 per year, 3.1 per year. Relative risk for a NOAC in terms of some other issues is improved, but indeed major bleeding is still an issue with the NOACs. If you're on an anticoagulant for a long enough period of time, you'll have a chance for bleeding. Makes sense and is real. And so what then could we say about the anticoagulants? They've been tested in trials with more than 60,000 patients. Bleeding rates are 2 to 3%. Major, any bleeding rate is 15 to 25%. It's terribly important that how we define bleeding may be different than how the patient defines bleeding. If we have a patient that every time they shave begins to bleed because they nick themselves, and then they come to the office with pieces of toilet paper all over, and somebody says, gee, that's a zit. Well, we might call that, in trials, a minor bleed. From the patient's standpoint, that's a big deal. That's a big deal. And discontinuation rates between 20 and 25% in major studies, and so maybe what we should do is to avoid some of the systemic complications by using then a local approach. With a local approach, there's 100% adherence. Once you get the device, you've got it. It's not like you can take it back to the shelf. And so let's then talk about what does the neighborhood look like. We've talked about the need. What does the neighborhood look like, and what do the devices look like? We have the option that we will choose, and we will talk with patients about between taking medications and then one of these devices. These are the two most commonly tested devices in this country, and the only one that's approved, the Watchman Device, and then the Amulet device. There are 3 major groups of these devices. One is an endocardial plug. That could be Watchman, or it could be the Amplatzer, or it could be Wavecrest. There are other devices. One is called the epicardial loop, which is a pericardial approach that is being tested in this country. And then there's a combined approach, a lariat device with a transeptal sheath and then an epicardial sheath where you then lasso the left atrial appendage to try to prevent clot embolization. What do we know about these devices? This is the very first trial. There were only 2 randomized trials in the world with these devices. This happened to be the first one. It was presented and published in 2019. What it did was to say we're going to take patients that are at high risk for stroke, and we're going to either give them a Watchman device or we're going to treat them with Coumadin. The randomization, as you can see, was 2 devices to 1 control. And what you can see if you were to look at the event probability, the Watchman device was either as good as or better than warfarin. And that then confirmed the concept that indeed most strokes occur from the left atrial appendage. That was the pivotal trial that documented that concept. Been a lot of information on the Watchman trials since that time. More than 2,500 patients and more than 6,000 patient years of follow-up. Striking thing about this piece of information is we talked about the fact that the oral anticoagulants, there are 60,000 patients. This is a drop in the bucket, but this is the information that we have. That is true. What do we know about it? This is a study that was just published a year and a half ago, looking at a patient-level meta-analysis of looking at left atrial appendage closure versus warfarin. Overall prevention of stroke or systemic embolism was spot on. What does that mean? Either that means that there were strokes that were related to the procedure, or not all strokes come from the left atrial appendage. We talked about the fact that it's only 90%. 10% of the patients have some other reason, whether that be carotid disease or something like that. And obviously, any local site-specific therapy in the left atrial appendage does nothing for carotid disease. Does nothing. But if you were to look at hemorrhagic stroke, it's dramatically less. It's 80% less. Hemorrhagic strokes are the worst strokes. Highest morbidity, highest mortality, and the highest patient quality of life, because most of those patients say, gosh, I wish I wasn't even here. Wish I wasn't even here. If you were to look at cardiovascular unexplained death, there's a 50% reduction in cardiovascular unexplained death. It remains unexplained. It remains unexplained, but that's the data. It was a 50% reduction. All-cause mortality was about a 30% reduction in all-cause death in the group of patients who received left atrial appendage occlusion device. Let's look at mortality reduction. Terribly important as we talk with patients. This is the mortality reduction of Watchman versus warfarin. This is in the group of patients in these trials who had a warfarin control limb. We can see that with dabigatran, irrespective of the dose, rivaroxaban and pixaban, we can see that the reduction in all-cause mortality swamps, blows everything away in terms of improvement in mortality. I think that is real. Whether it's the fact that patients on anticoagulation bleed from that is unclear, or whether they're doing things that cause them to get in accidents. It is unclear. Something about it, however, is real. Those patients that are on a device like this have improved survival. And they have improved bleeding. This is data from Matt Price, looking at bleeding outcomes after left atrial appendage closure compared with long-term warfarin. Once you get through the initial period in the catheterization laboratory, there's a 70% reduction in bleeding. Makes sense. If you're not on an anticoagulant, then you're not going to have the potential for anticoagulant-associated bleeding. These patients are incredibly satisfied. Those patients that you come in and you see them and they say, Josh, I'd sure like to get off that stuff, that rat poison. Because that's the term that they use, because we sometimes use that term too. They're incredibly grateful because at the end of a year, between 95 or 92 and 99% of the patients can get off of warfarin or get off of a NOAC or a DOAC. The next piece of information is this. This is a wonderful slide. Do not touch. How often have you been someplace and you did something and you said, oh God, I hope nobody sees me. I wish I hadn't done that. How often are there problems where we wish we hadn't done that? Well, anytime we take somebody to the catheterization laboratory, at least in Rochester, Minnesota, and perhaps here too, there can be some vascular complications. There can be some complications. And so we looked at that, and we looked at it in the initial trial, Protect AF, and then the second trial, Prevail. If we were to look at pericardial tamponade, which is the most frequent complication, we see it has gone from about 4.5 down to about 1% or a little bit less. in the group of patients that we're currently treating. So we're getting better with this. So that early complication hazard, while not zero, has been mitigated substantially. Mitigated substantially. Next piece of information is to say, well, gosh, this resulted then in the approval in March of 2015 that it's indicated to reduce the risk of thromboembolism from the left atrial appendage in non-valvular atrial fibrillation in patients who are at increased risk for stroke and are deemed by their physicians to be suitable for warfarin. So they had to take warfarin for 6 weeks. That's the information that the FDA approved, because that was the only information that they had at the time. If you were to say, where did that 6 week come from? I don't know. Nor does the FDA know. Nor does the manufacturer know. It became part of the lexicon. Of course, they have to be on anticoagulation for 6 weeks. Goodness sakes, we couldn't do it without that. But they had to have an appropriate rationale to seek a non-pharmacologic alternative to warfarin, taking into account the safety and efficacy of the device. That then resulted the next year in 2016, in February 8th of 2016, that CMS said, we'll pay for it. Sort of an important thing. We'll pay for it. Provided that they are at high risk, that's true, and provided that there's a formal shared decision-making interaction. This is pretty much the first time in the history of CMS where CMS linked reimbursement with shared decision-making. You're going to see this, I think, going forward for many different things. One could only imagine in the field of electrophysiology ablation, if, as you talked with a patient, you had to share the decision-making in terms of ablation, for example, for pre-excitation, between medication versus an ablation, and you had to go through this before you got to the point of reimbursement. Would have changed the field. The same would be true for PVI. Would have changed the field. Going forward, this will be the field. There will be reimbursement based upon shared decision-making. And the patients had to be suitable for long-term warfarin but deemed unable to take long-term anticoagulants. That was based upon clinical trials. This is a great cartoon. This randomized double-blind trial involving over 20,000 patients was conducted over a 10-year period. Unfortunately, we've forgotten why. So what then do we know going forward from this stuff that dated back to 2009? Well, we have this piece of information. It's the only piece of information like this that we will ever see, that we will ever have. From March 2015, when it was approved, to May 2016, there were 3,800 patients who underwent Watchmen by 382 physicians in the United States. But the only piece of data that comes from a device registry that was then vetted by the FDA. And so this is that group of data from this group of patients that will never be seen again, because all of them are going to be in a registry. This was the procedural success rate, was 96%. In the original trial, it was 90%, so it's gotten better and better. It's about 96%. In Europe, it may be a little bit higher. It's unclear whether that's a difference in technology, a difference in patients. We're not sure about that. But these were the complications in this 3,800 patients, just to make sure that it is safe when it is rolled out. Ralph Brindis coined the term rational dispersion. What are you going to do when you take this from very experienced centers to Peoria, Illinois? I'm not even sure where Peoria is. I hope nobody's from Peoria here. What are you going to do in Peoria, Illinois? Well, when it's taken out into widely dispersed centers, we can see pericardial tamponade is 1%, and most of the time it can be treated with pericardiocentesis. Mortality is 0.078. Procedure-related stroke is 0.078 also. It's a device, it's a procedure that is getting safer and safer. And so what did we conclude in this article of post-approval U.S. experience? Despite the fact that 50% were performed by inexperienced operators, in the real world, procedural success is high. It's 96%. Complications were very low. Mortality is less than 0.05%. Not zero, but it's very low. You might say, well, gosh, that's with Coumadin. I'm not even sure how to spell Coumadin anymore, because we use NOACs in all these people, or at least we start them on NOACs, or at least we think we use it in everybody. There's a multi-center registry. This is off-label stuff now. This is off-label, but that is true. That lives. Off-label indications live and are doing well. 2017, a multi-center registry of 214 patients undergoing a Watchman device who were treated with a NOAC versus patients who were treated with Watchman and then were treated with Warfarin as per the IFU. This was published in Heart Rhythm. This looked at the overall complications between the NOACs following Watchman and Warfarin following Watchman. There isn't any difference in bleeding. I'm surprised at that. I would have thought that there might be a difference in bleeding, but there's not. Maybe they're not as good early on as we thought they would be. But the most important thing that you want to know is, were they as free of complications of stroke? Stroke and TIA, systemic embolism, both peri-procedure and post-procedure, no difference whatsoever. What that means is that we can indeed, in an off-label way, that's true, I've got to be sure that everybody realizes that, we can substitute then NOACs for Warfarin in patients who are treated with a Watchman device. And the other complications, LA thrombus or embolic event, were similarly low in both groups. And so they concluded NOACs proved to be a feasible peri- and post-procedural alternative regimen to Warfarin for preventing device-related thrombosis and thromboembolic complications expected early after appendage closure. Terribly important part, and hopefully that then will become part of subsequent IFUs, working with CMS. The next piece of information is to say the world is a really big place. What do we know about the rest of the world? What does the rest of the world do with these sort of devices? We know that in the United States, as we've mentioned, the U.S. indication is increased risk for stroke, are deemed suitable for Warfarin, but have an appropriate rationale to seek a non-pharmacologic alternative. The rest of the world says, really? Why wouldn't I use it in anybody in whom you didn't want to use anticoagulation at all, or you couldn't use anticoagulation at all? And so the indications for use internationally is intended to prevent thrombus embolization from the left atrial appendage and reduce the risk of life-threatening bleeding events in patients with non-valvular atrial fibrillation who are either eligible, so they could take anticoagulant therapy, or maybe they can't take anticoagulation therapy. And that opens up the world to that group of patients in whom you see and whom I see and say, gosh, anticoagulation doesn't seem like it's the real thing, and you shouldn't be on that at all. There are a couple pieces of information. This is the Evolution study. It's a European study, multi-center registry of 1,000 patients, multiple different centers in multiple different countries to obtain clinical data on procedural success and 30-day outcomes of bleeding, stroke, and TIA. If you were to just look at this group of more than 1,000 patients, 70% of the patients had a contraindication for any oral anticoagulant therapy. And that's the group of patients that we are going for in this country. Will be the group of patients whether they have cerebral amyloid angiopathy, which is a real big deal, or they have other reasons to not take anticoagulation. You're not going to give them anticoagulation. Information from this data set and a couple of other data sets will help to inform that decision making. In this group of more than 1,000 patients, we can see that following the procedure, post-implant, 60% were on dual antiplatelet therapy. Almost 10% had nothing. Had nothing. And NOAC, 11%, Warfarin, 15%. So we can see that the world has moved on from saying they have to be able to take short-term anticoagulant therapy, and it's being used in patients in whom you cannot give them anticoagulant therapy. And this just looks at the 3-month data. You remember, 72% of this 1,000 patients were contraindicated in terms of anticoagulants. We can see that the number of events is vanishingly small. Strokes are 0.4%. What that would mean is that we do not necessarily need to use anticoagulation following a Watchman device. And so their summary was, all drug regimens appear safe. NOACs present the lowest bleeding risk, but there isn't any increase in thrombus on the device or stroke-related events. Leads the way then towards this picture. Yesterday's a closing door. You don't live there anymore. We used to live there with anticoagulation following Watchman. We don't live there anymore. If we live in Europe, we don't live there at all. How about in this country? We do know pieces of information. This is data that is being used for a fundamentally important trial in this country on a group of patients, 150 patients that came from Europe but has now been translated into the United States, in a group of patients who could not take anticoagulation, who were still at high risk for stroke, and who were treated with a Watchman device and then followed for 2 years. These were the results. Expected versus observed stroke rates, there was about a 75% reduction in ischemic stroke compared to what had been expected in groups of patients treated with just aspirin and no warfarin after the procedure. And so they concluded left atrial appendage closure with the Watchman device can be safely performed without warfarin transition. And it's reasonable to consider for patients at high risk for stroke, but with a contraindication to systemic oral anticoagulation. This then leads to the ASAP-2 trial in this country. I don't know whether you were in that in this center, but it will be the use of Watchman in patients who cannot be treated with any anticoagulant. The control group will be aspirin alone, for prevention of stroke in this group. How about the neighborhood? Just a couple of pieces of information on that. This is the amulet device, and I think you're potentially going to be involved with the trial of the amulet device. It looks very different, but it's a very, very important and good device that is being randomized against Watchmen in this country. This is the information that comes out of Europe, about a 1,000-patient trial that was just presented. And you can see the typical group of patients, 65% had a CHADS-2 VAS score greater than 4, and 60% had a HAS-BLED score greater than 3. It's a very high-risk group of patients. It's the sort of patients that we see, that you see, that would be terrific for a device like this. The reason for the procedure, again in Europe, was that 85% had a contraindication to anticoagulants. A contraindication. And the future is going to be that group of patients, I think, because it's a bigger group of patients. Implant success was 99%, and so the procedure can be carried out very well with the amulet device and similar to the Watchman device. It's going to be a very good device. It's a different device. They will be different patients. Angulation is different. The seal is different. There are different things about it, but it is a very real and important device. Major adverse events, mortality was again low and very similar to what we've seen for Watchman. Mortality related to the procedure is 0.3%. Embolization is only 0.1%. Stroke is 0.3%, so it's a very good device. So we will have multiple devices in this country to use for our patients. And in this device, most of the time, you get by with just dual antiplatelet therapy or single antiplatelet therapy. So it's again going to be devices that are friendly, user-friendly to use with low complication rates and are very effective. So they concluded that the amulet had high closure rates. Antiplatelet therapy is a very reasonable treatment strategy post-implant in the short term. Very technically high success rates. The final device is one that I will mention. Do you do lariat here?
We did.
Are you wild about it? Are you wild about it?
I am not.
Well, Dr. Valderbano's wild, period.
I'm not going there. So the lariat device is an extraordinary device, and again, I'm going to just mention an interesting piece of information. It's that combined endocardial and pericardial device It has high has high pericarditis rates, all sorts of things related to that. But the extraordinary piece of information is now a relatively old piece of information. It's 2 years old now, that comes from a multi-center registry of 50 patients with atrial fibrillation who were treated with the Lariat approach. And they then looked to see if Lariat exclusion decreased atrial fibrillation. The information, and you can comment on this from the electrophysiology literature, although potentially controversial, is that 25% of atrial fibrillation comes from, it lives in the left atrial appendage, along with thrombus that lives in the left atrial appendage. And so with this device that strangulates and necroses the left atrial appendage, does atrial fibrillation decrease? And this is the information. It's a tiny group of patients, a tiny series, but it's extraordinarily interesting that if you were to look at Lariat device for left atrial appendage occlusion, there is a substantial reduction in atrial fibrillation burden in all patients. Does it last? I'm not sure whether it's going to last or not, but at least early on the data suggests that potentially a device like this, and that would also be then germane for surgical approaches that get rid of the left atrial appendage. Maybe that'll improve atrial fibrillation control. So they concluded it appears to reduce atrial fibrillation burden. The presence of atrial fibrillation triggers in the left atrial appendage appears to be a strong predictor of atrial fibrillation reduction. Extraordinarily interesting. Whether it's true or not, whether it's just so selected is unclear, but it's interesting. So where do we stand? We've talked about the rationale. We see thrombus. It goes off to play. It's a bad deal when it goes off to play. Is there a need? There's a huge need. In the patient population, it's a huge need in this room. It's going to be a huge need in this room. What does the neighborhood look like? Well, we talked about that. What do we know about the devices? What about the issues? We're going to have to match therapy with the patient. There will be the amniote device. It's a different device. It's a very good device. It's a different device. And there will be indications for that versus indications for Watchmen. And then how will we get there? We will need more science. We will need more science on the way to getting there. And so what will it look like in the future? We will have a device like this. This happens to be the Watchman device, but it could be the amniote device. It could be the Coherix device. It'll be used in patients who could be treated with warfarin or NOACs. That group of patients that you see, you bring them into the office and say, well, you could have either this or this, and they say, gosh, I just assume, I'm only 60. I'm a young punk. Why would you want to give me something that I have to take by mouth for the rest of my life where you could put this thing in? You could put this thing in. Or it would be those patients who chose or choose not to be treated with it. So, for example, somebody who is in an occupation that is highly hazardous, and they shouldn't and don't want to be on anticoagulants. It'll be used in those group of patients with a contraindication to warfarin or NOACs, and then the future is going to be, I think, in concert with ablation. And that's really neat. That's really neat. And there's data on that in abstract form and in small series from Europe that will be an important group to look at. So in the final end, we all have hammers. And Mark Twain said, if your only tool is a hammer, everything starts to look like a nail. That is true. And if you have atrial fibrillation and you have hammers, you have to decide what you're going to do with that hammer. And in the past, there has been really sort of divergent thoughts about it, that some people, the hammer is a pill, and other people, it's either a surgical occlusion device or it's a percutaneous occlusion device. What we're going to have to do is move this into the shared decision-making process. Patients will have options. You will have options in talking about those options with the patient options. And we will have to then blend those in to optimize the care and individualize the care for that patient in front of you that happens to have atrial fibrillation that needs a hammer of some sort. For those of you that have taken trips with kids in the back of your car, you get to the point where your child says, "Are we there yet? Are we there yet?" We're still in this field for the last time. We're not there yet. We're well on the way to being there. But it's still work in progress. Thank you. You want to take some questions? Are you okay? Okay. It's a really neat field. I'm sort of wild about it.
So David, that was a wonderful lecture. First of all, if you are a fellow, sit down. Nishant, please. Wahaj, come on. Dr. Zogby is going to make an announcement for you in about 2 minutes. We'll take questions first. Miguel, you're wild.
Yes.
So let's hear from you first.
So a quick question on ASAP. So there were 6 patients that had device-related thrombus on the follow-up. This was out of 150 total. Only one had an event. But that makes me very uncomfortable. And when you try to translate that data with NOACs, I'm a bit confused as to how to approach NOACs and for how long. If I'm going to try to replace Warfarin, would you do NOACs for 6 weeks and then aspirin and Plavix for 4.5 months, or NOACs for 6 months, or what's your approach?
I think that's a crucial question. The incidence of thrombus on a device is low. That's true, number one. Number two, typically the thrombus occurs, and the thrombus can be seen with Lariat, it can be seen with Amulet, it can be seen with the Watchman device. Typically, it comes out of the thinger, the connector pin. And so you see something that looks like a little balloon sometimes that comes out of that. It's small. The follow-up of those patients, there's a small number of patients. The follow-up has been very good, but it makes people really uneasy, appropriately so. So the industry is working at approaches to that in terms of changing that connector pin. The present time when that is seen, typically what has been done clinically is either to give patients some Lovenox for a couple of weeks and then repeat it, and most of the time that's gone. But then that raises the question that you have said, is what do you do following that? Presumably, that connector pin issue relates to the fact that it has not been fully endothelialized. And if you then give them a burst of anticoagulant, whether that be a NOAC or whether that be Warfarin or whether it be Lovenox, that will give a chance for endothelialization to occur. Now, in the follow-up of those patients then, typically then you would for sure make positive that you did a follow-up TEE between 9 and 12 months after that. And by that time, most of the time it's gone, whatever that was that it was. And typically embolic events related to that have been tiny.
And a question about the finances of this, which are as much as they can be, but fascinating, because, for example, when you look at the combination of ablation with Watchman implant outside the United States, it's done mostly for financial reasons. The health systems will pay for the ablation, and then the patient buys the device and they get both. Here we can't do, or we're very much discouraged to do, because the hospital only bills for one procedure. Also, we are having enormous financial constraints as to how we use and how many Watchmans we use, because the hospitals claim to be losing money. Where do you see that fixed?
So, so I have data on this, but we can just talk about that. In the United States, it's a non-starter, combining atrial fibrillation and a Watchman or that sort of device. It's a non-starter because you're exactly right. Number one, there's no IDE study, nor is there apt to be an IDE study related to that. And number two, you will just get paid for whichever procedure you want, but just one. And so most hospital administrators, when you then sidle up to them and say, what do you think about that? It's a very short conversation. It's a really short conversation. So it's a non-starter in this country. However, abroad, it looks like it's a very reasonable thing, and patients are obviously wild about that. There are other issues about how long does it take, although it doesn't usually take that long. There are issues when you do it like that. If you then do the ablation first, does it change the diameter, the ostium of the left atrial appendage? There are some technical things that we could talk about. Doesn't look like that's a big deal. But in this country, the hurdle is financial, and until that hurdle is met, not going to happen here. Not going to happen here.
And Dr. Holmes, thank you very much indeed. I think that's an example of how to give a lecture, both in style and in substance. It's fascinating. I want to take advantage of the fact that you're here. This morning at Vascular Conference, we were talking about the new NeuroArc classification of stroke, which I believe you're a co-author on, and particularly type 2 stroke being defined now as cortical necrosis, asymptomatic clinically, MRI positivity. And maybe you can kind of outline the implications of that, you know, for the conversation around TAVR, for example. We're going to have to explain there's a 70% stroke rate to patients, because this is a whole new concept which I think has got profound implications for neuromonitoring, which we're interested in, and the conduct of advanced cardiovascular interventions in the heart and in the aortic arch.
I think that's a crucial question with profound implications, as you have said. Number one, that document, when we brought together a zillion people to make that document up, it was specifically focused on what things were needed for clinical trials, was not focused on definitions and testing for clinical practice, because it was realized that you couldn't possibly, in outside of trials, be able to do that. That's number one. Number two, it raises the issue, though, of how do we define strokes following these procedures. That was first, as you know, well, not first, but it was raised to a high level in the Philadelphia randomized trial of CABBAGE, where they then looked at patients who were treated with CABBAGE, and then they had neurologic testing afterwards, and it turns out in that trial, and you would know it better than I, the clinicians said, oh, there was a stroke in, I don't know, 12% or 10% or something like that. When neurologists looked at the patients, it was a 20% stroke, and when they did diffusion-weighted MRI, it was 70%. We don't have a clue what to do with that. It's unclear. There aren't a lot of places that are going to be doing diffusion-weighted MRI from a clinical standpoint, unless there is a specific implication. That's going to even get larger in the whole field of structural heart disease, including atrial fibrillation, with the question of cerebral amyloid angiopathy, which can only be seen, despite the Boston score and all that stuff, can only be definitively diagnosed using MRI. And so I don't know the specific answer to that. I think that using the NeuroArc definitions, we will then be able to test new devices to prevent that abnormality. At the present time, there probably isn't going to be any randomized trial where the primary endpoint is going to be non-clinical diffusion-weighted MRI, but we will test devices in that group of patients with that as an endpoint. That's not a very complete answer, but there isn't a very complete answer available, but it's a huge issue.
David, a pleasure having you. An amazing lecture as usual. Question to you is, seeing the different indications in the US versus Europe and the strength of the data for safety, long-term safety, how can we expand the indication in the US? Do we need further trials? Is it, just give us a feel of
Sure.
how can we get to having a choice.
So the biggest expansion of indications will be the group of patients who have a contraindication that you don't want to use any anticoagulant. That'll be the biggest bucket. It turns out this is an interesting sidelight that's an important sidelight. When the initial Watchman stuff was taken to the FDA said, this is not the trial we want. Why are you doing this trial? They said that the The trial they wanted was in a group of patients in whom anticoagulation was contraindicated. How we will move to that, unfortunately in this country, will be the ACEP2 trial, which randomizes patients that have a contraindication to warfarin or any anticoagulant to the device versus aspirin and Plavix as a control. That's going to be a 5-year trial. Now, the only ray of light will be the Amulet trial, which may finish sooner. The Amulet trial is Watchman versus Coumadin versus Amulet with aspirin. And then CMS might look at that and say, we now have enough data to say it's okay. Final piece of information is, as you know, there's a left atrial appendage occlusion registry from NCDR. The hope is that there would be enough patients in that either don't get warfarin or don't get anything afterwards, that CMS will look at that similar to what was done with the TVT registry to expand the indication for TAVR from inoperable to intermediate group. And hopefully CMS and the agents and the FDA will look at that and there will be enough patients to say, gee, this looks like it is a good thing. We'll continue to follow up with the post-market surveillance. So a couple of different approaches we're not sure with, but I think that's the goal.
Still some ways to go, right?
Mhm.
Well, can I ask the faculty as well, the fellows, for our yearly photograph to go immediately after this? Don't straddle, please, to the Research Institute so we can get the photograph. And David, thank you for being with us. An amazing lecture. Thank you.
It's so great to be here. It's great to see you.
It's great to see you, man.